Alright, in this video we will be discussing about dizziness and vertigo. See, dizziness and vertigo are very common complaints with which the patient often presents to the OPD. Let us dive into the definitions of dizziness and vertigo first of all. Right. Dizziness is an imprecise symptom which is used to describe a variety of common sensations. I meant to say that dizziness is a very vague kind of symptom. You cannot specify and tell someone that he has dizziness and the diagnosis is this or that. No, dizziness is a presenting symptom. Now you have to delineate that to what actually the patient wants to refer. It is used to describe a variety of common sensations that include vertigo, lightheadedness, faintness, and imbalance. Right? Any of these symptoms can be dizziness. Then what is vertigo? Vertigo is you can kind of specify a little. Vertigo means spinning. Whenever patient tells you that I am having vertigo, he means that he is having a sensation of spinning the head, spinning his head, spinning the environment. Right? There is everything spinning inside him. So that is called as vertigo. Now, for the purpose of understanding, we have to differentiate that vertigo can be physiological or it can be pathological. Physiological is like when you spin around for a while, your head or the environment will start spinning. It is physiological. Sometimes there is some uh, pathology in the balance system of our body. The vestibule, the vestibular nerve, right, and the brainstem nuclei, they all are responsible for maintaining the balance. Whenever there is a lesion in uh, this machinery, whenever there is lesion in any of these parts, it will lead to pathological vertigo. Right. What is lightheadedness? Lightheadedness means pre-syncopal sensations resulting from brain hypoperfusion. That is very common. I think that is very easy to understand, that if someone complains of lightheadedness, it means he is having some brain hypoperfusion. He is having darkness right in front of his eyes. The patient may even fall. The patient may even go into syncope. So this is a pre-syncopal sensation, right? Many of the times the patient will feel lightheaded and then they will faint. So this is a pre-syncopal sensation. It is very important to understand these three terminologies, right? Dizziness and vertigo is the main heading under which we are discussing all these things. In which unit do we study dizziness and vertigo? We study it in neurology. So it is a part of neurological examination or neurological symptomatology. Now, going forward, what are the causes of dizziness? Right? Dizziness can arise from dysfunction of any of the system which is involved in maintaining balance of the body. It can be vestibule, it can be hypoperfusion of central nuclei or hypoperfusion of brainstem or hypoperfusion of brain in whole. So causes of dizziness can be divided into vestibular or presyncopal dizziness. In vestibular dizziness, it occurs because of peripheral disorders like labyrinthitis or vestibular neuritis. It may be paroxysmal, or it may be due to some fixed unilateral bilateral deficit, right? It can be paroxysmal, it can be permanent when there is a permanent lesion in the vestibule or permanent lesion in the eighth nerve or permanent lesion in the brainstem nuclei which occurs in stroke. So that can cause fixed vestibular dizziness. Now coming on to presyncopal dizziness, whenever there is hypoperfusion of the brain. When does hypoperfusion of the brain occurs? Hypoperfusion occurs in case of stroke, whether it is hemorrhagic, whether it is ischemic stroke, or it can occur in case of arrhythmia, or it can occur in case of shock. So any cause can lead to brain hypoperfusion, and it can lead to presyncopal dizziness. Right, it occurs due to cardiac arrhythmias or systolic hypotension, medications, or other causes that lead to brain hypoperfusion. So these are the two causes of dizziness that we have to delineate. How do you approach the patient with dizziness? Before this, we were just discussing the introduction part of dizziness and vertigo. Now we have to approach the patient with dizziness when he comes to the OPD. First of all, we have to take history. In history, we have to look for 5 things. First, we have to differentiate between vertigo or imbalance. ठीक है. Second is the symptoms accompanying vertigo. Third is the duration of dizziness or vertigo. Right. After that, mm, after that, all right. I have covered these three. I have covered all the points in these 3 headings itself. Vertigo versus imbalance is the first point. Vertigo implies an acute asymmetry of vestibular inputs, whereas symmetrical bilateral vestibular hyperfunction causes imbalance and not vertigo, right? When there is acute asymmetry, it is vertigo. Whenever there is symmetrical bilateral vestibular hyperfunction, it is imbalance, but not vertigo, right? If it is symmetrical, it is, if it is asymmetrical, it is vertigo. If it is symmetrical, it is imbalance, right? Then what are the symptoms that accompany vertigo? If there is unilateral hearing loss and some oral symptoms like pain, right, it points towards a peripheral cause. See, we have to delineate the cause of vertigo or dizziness whenever the patient presents to us. The causes are divided into peripheral causes and central causes. If there is a central cause, it is it can be a more, severe or more grave kind of cause, right? But when there is a peripheral cause, it is kind of peripheral only. I mean, there can be permanent damage, there can be temporary damage, but it is peripheral. We have to delineate that what is actually happening, because the pathologies or the pathogenesis of these two causes are very different, right? So unilateral hearing loss and oral symptoms, they point towards the peripheral cause. Central lesions cause bilateral symptoms, very important, because the balance pathway or the equilibrium pathway, when it enters the brainstem, it becomes bilateral. So if there is a central cause, it will cause bilateral lesion only, right? It is, two-sided representation. But if it is a peripheral cause, it will be unilateral most of the times. Symptoms like double vision, numbness, and limb ataxia, they suggest central lesion, right? Third point is dizziness and its duration. We have to, know about the duration of dizziness. With duration, we can delineate the underlying cause. If it is brief, it is BPPV or orthostatic hypotension, and these both are associated with change in position. If it lasts hours, it is caused by vestibular migraine or Meniere's disease. Intermediate duration dizziness is caused by TIA. If it's intermediate duration, means for some hours, less than 1 hour or so, it is caused by TIA, right? So duration is very important. So 3 points: vertigo versus imbalance, you have to differentiate between the two first of all, then symptoms accompanying vertigo, and then dizziness and its duration. Very nice. History we have taken. Now we are coming on to examination. Peripheral eye movement disorders are usually disconjugate. Whenever there is vertigo, there are disconjugate eye movements. Then 2 points: pursuit and saccades. They usually indicate central pathology, often involving the cerebellum, right? Pursuits and saccades are a symptom of, are signs of cerebellar pathology. So poor pursuit and inaccurate saccades, very important, very, these are very kind of new terminologies even for a MD medicine. Whenever when he just enters the MD medicine, these are, very difficult uh, to know about the pursuits and saccades. These are kind of new symptoms or new signs that you have to assess in a patient, but these are very important. Pursuits and saccades, they point towards cerebellum. Then is the nystagmus. Nystagmus is also found in cerebellar lesions. Then bedside test of vestibular function is head impulse test. We rotate the head to the sides by 15 to 20 degrees at a high frequency, and if the patient cannot follow the direction of the movement of the head, it is abnormal and it is found in cerebellar lesions. So bedside test of vestibular function is head impulse test. Then is the Dix-Hallpike test. It is used to diagnose posterior canal BPPV. It is almost diagnostic of posterior canal BPPV. Then dynamic visual acuity. Dynamic visual acuity is when you rotate the head of the patient and you try to assess the visual acuity of the patient. If the visual acuity drops by one line on Snell's chart, right? If the visual acuity drops by one line on the Snell's chart during head rotation, from side to side, this fall in visual acuity is abnormal and it indicates vestibular dysfunction, right? Like we did have head impulse test, which is a test of vestibular function. Similarly, dynamic visual acuity is also a test of vestibular function. Now vestibule is peripheral organ and cerebellum is the central organ. So pursuits, saccades and nystagmus, they will be found in cerebellar lesions, while head impulse test, Dix-Hallpike test and dynamic visual acuity, they will be found in vestibular dysfunction, and these are the peripheral causes of vertigo and dizziness. So this is the examination that we have to do in a patient who is presenting with dizziness and vertigo. Now ancillary test. Ancillary means additional tests. We can do audiometry, we can do video nystagmography, caloric testing, and MRI of internal auditory canals. Right? These are the ancillary tests. What is the differential diagnosis of this thing? Differential diagnosis of vertigo and dizziness. See, these 8 DDs, they require another 2, 3, 4 lectures in themselves. So I am just telling the names of the diagnosis, and I will be covering these topics in other videos. For the purpose of remembering, you have to go through all these 3 causes, all these 8 causes, and remember them by heart. I will be explaining them in detail in other videos. First is the acute prolonged vertigo or vestibular neuritis. Second is BPPV, benign paroxysmal positional vertigo. Third is the vestibular migraine. Fourth is the Meniere's disease. Fifth is the vestibular schwannoma. Sixth is bilateral vestibular hypofunction. Right? Central vestibular disorders. Psychosomatic and functional dizziness can also be there. So these are the 8 differential diagnoses of dizziness and vertigo. And you can, differentiate between these on the basis of history and examination and some ancillary tests that we have just discussed in the previous slides. Right? Now coming on to the treatment. Treatment is different for different entities, but for the purpose of simplifying the things, we can remember that what do we give, what do we use mostly to treat vertigo in OPDs or in wards. First category of drugs that we use is antihistamines like beta-histine. Beta-histine is available in the market by the brand name of Vertin. Then we can use benzodiazepines like clonazepam. Anticholinergics can be used. Physiotherapy can also be used because sometimes the causes of vertigo are irreversible. So we have to train the patient so that he can, adapt well to the deficit, and he is able to carry out his routine daily activities. So physiotherapy is for the purpose of rehabilitation. Then there are other therapies like cognitive behavior therapy, or when the patient is functional, you have to treat him accordingly with the help of SSRIs or anti-anxiety drugs and cognitive behavior therapy. etc. So these are the categories of modalities that we used for the treatment of dizziness and vertigo. So that is all about dizziness and vertigo, and I will be discussing the causes of dizziness and vertigo that we have just seen in the slide of uh, differential diagnosis. I will be discussing those causes in detail in the coming videos. So that is all about today. That is all about this video. I hope you have learned a lot from this video. That is all. Thank you so much.